Welcome to the American Association of Critical Care Nurses Voices in Nursing podcast, exploring critical care nursing through meaningful and inspiring conversations. This episode is sponsored by AACN's Beacon Award for Excellence, offering unit-level recognition for exceptional units, with information available at www.aacn.org/unit recognition. Now here are your hosts, AACN's Chief Clinical Officer, Dr. Vicki Good, and Clinical Practice Specialist, Andrea Schmidt.
Welcome to the Voices in Nursing podcast. This is Dr. Vicki Good, AACN's Chief Clinical Officer, and I am joined by my colleague, Brandee, one of AACN's Clinical Practice Specialists. Brandee, I have worked in the patient safety specialty for many years, and one of the things that I have seen over and over is the impact that communication has on adverse events. The biggest communication issue I frequently observed was the impact of silence on adverse events. The 2005 Silence Kills report was truly influential in my patient safety practice.
As I read that 2005 Science Kills report, I was so shocked to hear that only 10% of clinicians were willing to speak up when they saw their coworkers breaking rules or making an error. This report came out as AACN was releasing those healthy work environment standards for establishing and sustaining healthy work environments, where skilled communication is one of those 6 standards.
There was great synergy between the Silence Kills report and the HWE standards. So one day I was checking email and I got an email request from our guest team to work on the next version of Silence Kills, or the Silence Kills 2.0 study that we're calling it. And it was an easy yes for AACN to participate in that work. So our guest today is Joseph Grenny, and he is the co-founder of Crucial Learnings and a New York Times best author. And when I found out that I was going to have the opportunity to work with Joseph, I was absolutely beside myself. And many of you probably know Joseph from his work with Crucial Conversations. I still have my Crucial Conversations book, and it still has multiple tabs in it. And I refer to that book frequently. So, Joseph, will you take a few minutes to introduce yourself to our listeners?
I will, thank you. And it's delightful to be here with you, Vicki. I think I felt just as excited about our potential partnership as you did, it turns out. So what a wonderful experience this has been. Our assumption is that human behavior matters. So the place we come from at Crucial Learning is that at the end of the day, in spite of advances in technology and science and so forth, at the end of the day, most things matter. Most things depend on human beings. Nowhere is that more true than in healthcare. So we can come up with terrific clinical advances, but ultimately it's a whole bunch of caregivers that have to coordinate their activities in order to deliver the best evidence-based care. Some studies years ago, and I think they've been replicated since, have shown that the average patient might get as little as 50% of the best evidence-based care available. Now, that doesn't mean that we're making the massive mistakes, but even small omissions occasionally can compromise the quality of care that we're trying to give. So the question for us became, how do you get this human system to operate together well? We found over 40 years of research that one principle describes most of what the challenge is in our human systems, and that is this: that you can tell them the health of a relationship, you can tell the health of a team, you can tell the health of an entire organization by looking at one simple thing, and that is the average lag time between when people see it and they say it. That's it. Between when I'm concerned about something and I express it, between when it's a problem and when it's a discussion. And so the longer the lag time, the more the passivity increases, the more resentment occurs, the more silos, the more mistrust. So you think about that in a personal relationship, in a marriage, or a committed relationship in our personal lives. If there are problems and we're not talking about them, they get acted out. If you don't talk it out, you act it out. How does it get acted out? Passive-aggressive behavior, resentment, withdrawal, and politics, and silos, and name-calling, and gossip, and all of that happens in the absence of conversation. And all of the good stuff happens in the presence of it. So our ability to talk about things matters, but nowhere does it matter more than when we have emotionally and politically risky things to discuss. And that's where we and AACN partnered back in 2005 to ask the question, are there a handful of those kinds of issues that profoundly affect our capacity to give both the best quality of care, but the best quality of caring as well, to improve our human system's ability to do that. And as you've cited, the study showed there were remarkable relationships. There is no way for a human system to offer its best without us being able to step into these moments of vulnerability and interpersonal challenge at times and talk about broken rules or mistakes or mistrust or any of the 7 crucial conversations we originally found. So that's what brought us to today's discussion.
That is so wonderful. I'm so excited to jump into this. You did mention in 2005, like I don't want to date myself, but 2005, I wasn't quite a nurse yet. So, however, though, by the time I was a nurse, the silence kills data was already out. So it was something that we had talked about when I became a nurse. So super great. But 20 years ago. So can you explain like the genesis of that origin of that study and like kind of what those key insights were?
Well, as the 20th anniversary approached, we in AACN began talking about, is there a need to question whether or not there's been improvement? And so that was thesis question number 1, was have we gotten any better at this? So as you mentioned at the top of our podcast, the original findings showed that there are as few as 10% of people that speak up consistently in these kinds of moments. That's shocking. That's horrifying. So there was a lot of room for progress. And this isn't people that don't care. There's a whole complex of reasons that this doesn't happen that the healthy work environment standards really help to address. So we wondered, has it improved? But then we started talking as well about today's reality. I was part of a large healthcare conference about a year and a half ago that I mentioned to Vicki in our first conversation, that where the CEO of a large healthcare organization got up and talked about the tremendous opportunity available because of artificial intelligence and machine learning. This person said, we have data sets of patient experiences that we can mine and develop better clinical practices and produce better outcomes and better technology. And the world is going to be our oyster, in essence.
Mm-hmm.
Well, I got up after him, and this is one of those spontaneous moments of insight, and I hope he doesn't hate me after this, and I said, let me take a mild exception to that. And I pointed out that we already have a mountain of evidence that we don't use consistently in our clinical practice. And so the problem isn't always finding new insights, it's getting the human system to absorb and apply them. And what started spinning in my head in that moment is, I wonder if there are crucial conversations that affect a system's capacity to absorb and implement new knowledge. I wonder if the speed with which things get implemented depends in part around there being peer accountability. Specifically, people speaking up, reminding, holding each other accountable, challenging sacred cows. If that affects the pace of implementation, I wonder if you were to take 2 hospitals of similar size and similar markets with similar acuity, if you'd find there were profound differences between one and the next in their ability to learn something new and then put it into practice. So that was the thesis question. I bounced this off of our AACN colleagues, and they resonated with the question. They wondered just as much as I did if the human systems vary in their capacity to absorb and implement. So that was a second big part of this study. We wanted not just to ask, have we gotten better at speaking up about those previous 7, but are there others that will determine the pace of innovation in healthcare for the future?
Yeah, and I think, Joseph, a lot of the issue now is there's this big assumption that AI or technology, whatever umbrella you want to put it under, is going to replace the human being, especially when it comes to communication. Oh, I'll just text that, or I'll send it, via secure chat or whatever. But there's still where healthcare is an environment of human beings trying to work together to take care of other humans. And so we still have to have those conversations. So looking at silence and, communication 20 years later, what are the key insights that we're finding?
Yeah, the good news first, we'll address that, is that we have gotten better. So, and a lot better. And so from a 10% baseline and speaking up about the 7 crucial conversations, we're now about at 32%. So we're more than triple what we were before. Now, anybody that just heard us say that number is thinking the same 2 things that all of us felt when we read it, which is yay, and it's a really limp yay. um, because 32% means there's still many, many missed opportunities. But again, we ought to acknowledge that this means we can improve. This means we can get better. This means that this is a lever that we can pull. And so if we got from 32% to 40%, 50%, 60%, how much better would we be doing? The fact that we got from 10 to 32, how much better are we already doing? So this is a hopeful finding. So that's
Yeah, and I want to add, we had around, I think it was like 4,900 participants. It was just shy of 5,000 participants in the survey. The majority of them were critical care nurses or emergency room nurses. And traditionally, I don't want to stereotype, but traditionally, ER nurses and ICU nurses are much more likely to speak up. So I think I was one of those that was like, okay, great, we've improved, but 32%'s not that great of a number from my perspective, at least.
Yeah. And if we did have a true representative sample that wasn't stacked heavy for critical care nurses, to your point, would that number be 20% or 25%? So again, I think our original study was heavily weighted on critical care nurses, so there's reasonable comparison between these two. But I think what you're suggesting is that there's probably even more opportunity in less critical areas of the hospital.
So you've talked a lot about the Silent Skills 2.0. I'm really interested in like what was different between the original study and this study. I know you said it was both heavy in critical care nurses, but is there any difference in how the study was? Or I know we talked about the results, but what about the actual studies
Yeah, the
itself?
sample size was much larger, but the primary difference was this second question, whether the capacity of a hospital or a clinical setting to absorb new information is related to any specific crucial conversations. So that was a brand new question, and the findings there are just remarkable. What we found is that some hospitals, some clinical settings are 3 to 4 times better at absorbing knowledge than others. 3 to 4 times better. These are not marginal little differences. So some are terrific at hearing something new, checking out the clinical evidence, saying we're going to do this, and then doing it within a matter of weeks or months. Others can linger for months or years and only partially implement. So I'll give you just one case in point. I mean, as we all know, some of the biggest risks in any hospital setting are in labor and delivery. And so this is a setting where if things start to get compromised with mom or baby, that there's a possibility of bad things happening. Well, one of the most obvious interventions to help track and ensure that we're doing our best is a fetal heart rate strip. So we apply this to mom and baby and we check heart rates. And the problem with that whole system is the way we assess potential risk is on these broad categories of 1, 2, and 3 at current risk levels. So category 1 means that mom and baby are doing just fine, just proceed as normal. Category 3 is we're in an emergent condition and we need to do crisis intervention here. Category 2 is this big fat category that lumps all kinds of different conditions in, and you can lose a whole lot of opportunity to intervene because it's such a broad category. Well, this is a great opportunity for AI. But if AI tells you that this is a high level 2, a high category 2, not a low category 2, the problem is our current human system might be one where a nurse or doctor think they know better. Or a nurse is reluctant to wake a doctor up in the middle of the night and tell the doctor that, hey, it's still category 2, but it looks like it's progressing. Or it could be one where somebody has a belief that their own clinical judgment exceeds what AI is offering. So there are all these human factors that will blunt the effect of AI, and that's where these crucial conversations matter. So we asked, are there some that determine the pace of implementation? And here they are. Number 1. Do people speak up and point out concerns that indicate a need for innovation? Are we doing that? Number 2, do we remind each other? Do we nudge colleagues when they default to a past routine instead of improved methods? Number 3, do we hold each other accountable? So do we offer direct and immediate correction if somebody is stepping out of the new potential standard? And number 4, do we challenge sacred cows? If somebody's ego or habit is going to have to be challenged, do we step into that moment? So this study asked, are there variations between different care settings in how they handle these moments? And number 2, do they relate at all to how quickly innovations are implemented? And as I said before, they make a 3 to 4 times difference. These are the physics of the human system that determine how quickly we absorb. So this is a very important finding. For any who are betting on AI in the future, it's a naive bet unless you deal with the social system that has to complement
Mhm.
it.
Yeah, because I mean, humans ultimately have to use it. And one of the concepts that you all introduced to me was this concept of behavioral agility, which I was fascinated by. And I have to admit, I had to go and look it up a little bit and learn more on it because I didn't know much about it. But we really looked at that element in this study is how agile are we really as human beings and changing our behavior? And some of this is what we found is that we're not really that agile. So, what do you what conclusions do we come from that?
Mm. Yeah, I think the biggest conclusion, if it's okay to use a sports example, and I'm not a particularly sportsy guy, but I've heard this controversy recently about the Kansas City Chiefs tush push. If anybody's heard that term, I assume everybody's heard it.
Yes.
It's just a cool term.
Well, I'm from
I was
Missouri,
like,
so you're
yeah,
talking
she's
my
a
language.
huge Chiefs fan. Huge
That's
Chiefs
right.
fan right here.
Taylor Swift is there, so everybody knows about the tush push. And
Right.
so, there's been this big fight to say, should they outlaw it? It's not fair. It's an unfair advantage. Well, for crying out loud, every other football team could be absorbing the same knowledge. I mean, watch the tapes for crying out loud. And we
Right.
all ought to be able to do the tush push if we wanted to. But the problem is, different human systems struggle to absorb new knowledge. And if they can't absorb the tush push, imagine all this AI information that we might try to push into healthcare that people are going to struggle to absorb because a doctor doesn't want to do it this way, or the nurse preceptor told us to do it a different way. And so you've got all these resistances that are human. How do you overcome those? Here's the principle. The principle is that the health of any social system is a function of the lag time between when people see it and when they say it, between when they feel it and when they discuss it. So shrinking lag time, the lag time between when we learn a new idea and when we start holding each other accountable to apply it, that's the key. That's what sets the velocity of our capacity to absorb new knowledge. So as you described it, Vicki, we call this behavioral agility. If you have a social system, if you have a hospital that is not behaviorally agile, that isn't good at reminding each other, challenging sacred cows, holding each other accountable, that can't do that well, don't plan on a whole lot of innovation.
Yeah.
I'm not gonna
And I
lie, like
do
I just had to Google tush push. I just want to put that out there. That is a very interesting concept, I have to say. The behavioral
well, and
agility for other teams would be
Yes.
interesting
yeah,
to hear.
and Brandee, I do have to go on record though, because my Texas roots, I'm a true Dallas Cowboy fan at heart.
Oh, the
So
truth comes out.
yeah,
Oh no.
living in Kansas City, you do have to root for the Chiefs though. But
Ah, the more you know. Okay, going back to the study, now that we know that. Now we talked about some of the good results in the study. I know we talked about the increase, the 33% and all those things. Were there other key positive results that you can share with us?
That was the primary good news, was just the overall. We could go point by point with the different crucial conversations, but the headline here is that we have gotten better. Some of that is probably societal. I mean, we've had the Me Too movement where people learn to call things out, speak up. We've had a whole lot of challenge in speaking candidly in public in other ways during the pandemic and so forth. Some that's actually pushed the other direction. But I really believe what AACN has done around healthy work environment, I hope that some of what Crucial Learning has done in promoting the concept of that there are these moments of political and emotional risk that matter in producing the outcomes we've got, that we can actually speak up, intervene, and make progress. So that's the headline.
yeah, and I think for me, one of the biggest takeaways for nursing is that those environments that were positive showed greater behavioral agility. So there was a direct correlation there. But are there any other things that you think that nurses should walk away with from this new study?
The most hopeful thing is that we often feel despair because we'll say you can't speak up because of power differentials, or you can't speak up
Mm.
because of different experience differentials, or there are all these sort of barriers and inhibitors. But what the study clearly shows is lots of people are speaking up. And so at the end of the day, a lot of this has to do with our willingness and ability our competence at stepping into these moments, and not in an offensive way. This isn't about banging the table or pushing people around or becoming a bully. This is about learning to speak in ways that create psychological safety for others, but also candidly express the problem that you're trying to raise. And we can already be doing this. This is an issue of peer conversations with doctors, peer conversations with nurses. It isn't even always about the power differential. I think oftentimes we use the power differential as an excuse. It's a post hoc justification for not speaking up. And so I already know I'm uncomfortable doing this. We already dread these conversations. And if I can give myself a reason that helps me feel like a decent human being for not speaking up, like, for example, well, that's a doctor, and all they care about is getting that doctor's billings, and they're never going to challenge that doctor, then I can sleep at night. Well, no, that excuse is off the table, because 32% of people are already speaking up in some of these challenging moments. They're not being fired, and they're saving lives potentially as they do it. So I think that's a big takeaway, is it's not that tomorrow you're going to wake up and necessarily handle it all differently, but that you can get better at this. You can learn.
Mhm.
How about those that kind of set, those leaders in your organizations, your physicians, those kind of people, the power dynamic you had talked about? Like, what are the implications of the study for the leaders and how to set this?
Leaders have to set the tone. We found, for example, that people reminding others about hand hygiene could increase. One hospital where we attempted this intervention I'm about to describe, they went from the low 50s and high 40s in hand hygiene compliance to over 90% in 30 days across a 10,000 person organization. Remarkable, remarkable change. And one of the primary interventions was ensuring that every physician in the hospital was trained when somebody reminded them to say a magic word: thank you. And they had it drilled into them. They were required to get together for a 15-minute practice session on the unit where they practiced, or with any of the colleagues they worked with, to have them practice walking into a room, having somebody remind them, oh, you didn't wash in or you didn't wash out, and having them say thank you. And it's a simple thing, it's a simple gesture, but it has powerful psychological consequences. So you ask, do leaders matter, and do leaders have to sort of model and encourage this? Absolutely, that helps. It doesn't take others off the hook. We don't need to be waiting until they do. All of our research on crucial conversations was done under conditions where somebody had to raise an issue with somebody who was more powerful than them and who had a track record of not being a very good listener and very open-minded. So all the skills that we've studied in crucial conversations work under those conditions. And so it's important that both sides are working the problem.
Yeah, and I think there's so much power in psychological safety and making people feel comfortable in speaking up. And that's one reason why I absolutely love crucial conversations, because it really teaches those skills to make you confident in speaking up. And it's had such a positive influence on our healthy work environment standards, because if you don't have that right work environment for people to feel comfortable, then you just don't get anywhere. So, do you have any practical pointers for how do we reverse the impact of silence on healthcare? Just little simple things that people can do.
Yeah, I think to your point, one of the biggest findings in our research on crucial conversations is that safety goes both directions. So if you think about the power differential, you think about a high billing, long tenured doctor and a brand new nurse. Um, and uh, and so that would be a terrifying setting for anybody to walk into if I'm the nurse and wanting to remind or challenge a sacred cow. And what we found is that all of us can acknowledge that the very seasoned and respected physician has a responsibility to create psychological safety for the nurse. That is true. What we don't properly appreciate is the nurse has the responsibility to do the same for the physician. We're just human beings at
Mhm.
some level. And yeah, there are different diplomas on walls, or amount of years that we've served or something like that. But both of us come into these moments feeling apprehensive, feeling concerned, feeling ego threatened. And so the psychological dynamics are precisely the same. And so, one of the most important tips is realizing before you bring up any of these issues, whether I'm the nurse or the doctor in this position, create psychological safety. Create two conditions: mutual respect and mutual purpose. Help ensure the other person knows you respect them. and help ensure the other person knows you care about their problems, their interests, or concerns. Doctor, I know you're in a hurry. Now might not be the right time to talk. There's something that just happened when we were working together that I need to address. Do you want to do it now? Do you want to do it later? That little moment of just acknowledging the doctor's busy, showing respect for their time and their demands and their needs, asking permission to do it in an appropriate time. Those little signals create a sense of safety for the other person and make it more likely they'll be open. So we who are in lesser power positions need to realize we have enormous responsibility for psychological safety as well.
Yeah, I tell people all the time, I need you to have my back because I may miss things and I need you to point it out because we're all a team trying to achieve the same goals.
Yeah, and that little signal matters a lot. Now, Vicki, you're illustrating one thing that's important, and that is setting kind of generalized psychological safety, letting people know that in general, I want you to know I'm open. The problem is if it's not matched by situational safety. So now we're in the moment, and now I've got something I've got to say. And boy, it has to do with something that I know Vicki thinks that she's really smart about, and I'm about to challenge her on. You need to also make those same expressions in the moment, or even the generalized reassurance doesn't matter. I've got an open door policy. Anybody can come anytime. And well, that's different than when I'm about to tell you that you just royally screwed up with that last patient.
Yeah.
This is like life advice. I kind of feel like I'm in therapy. This is
Doesn't
like
it?
goes across not
Yeah.
just in healthcare, like everywhere. I think that
Yeah.
it's great.
Well, and
I'm
that's
going
the
to challenge
beauty of it is
Vicki.
you get better at it in the workplace, you get better at it at home, and you get better at it
Right.
at home, and you'll translate that to the workplace. This is about how we show up as human beings.
I think that's really great to remember. It's like one, we're all in it together. We're all in it to get for the patient care. There is a common that mutual purpose. Also, that people are human. We all, put our pants on one leg at a time. Isn't that what they say? So,
I can
so
give
how
you
about,
one more motivation for that, if that's okay.
of course.
And this I can't say from a social science perspective, but I can sure tell it from a life perspective. That I've found that all lasting happiness in life is about our capacity for two things: truth and love. That if all lasting happiness is really about our ability to create deep, intimate, abiding relationships with other human beings, then the two constraints on those are truth and love. It's our ability not just to be loving and kind and patient, to not give up on others, but also to be absolutely honest in those relationships. No real connection happens if there's love but no truth. Love but no truth is just collusion, and truth without love is just coercion. It's just bullying. But truth and love together, that's where the magic happens. And we need that in our workplaces. We need that in our personal lives. And so if that's an additional motivator to us to get better at this, it doesn't just save patients' lives, it makes ours richer.
Incredible. Incredible. So it's like crucial conversations, everything that you've done. It really gave us those tools, the tools to use. And then silence kills really shows us the cost of not using them in healthcare. So it's
Yeah.
like really, really thing. And I know you talked about the behavioral agility. I know we had mentioned that that was something that came out of the 2.0 study. In that aspect, what is something differently we could do to improve that for our teams?
Well, the same thing we've been working on for the last 20 years around the 7 silence kills conversation. So happily, these draw on the same skill sets, the same solution sets. So all we're doing is pointing out 4 more emotionally and politically risky kinds of situations that drive or inhibit innovation in healthcare. Again, the capacity of our ability to innovate in healthcare, to advance and progress, is a function of a social system that can talk about these 4 things. And so if we just work on our ability to hold crucial conversations, these 4 will get better. If we can get that number from 32% to 50%, we'll be able to start harvesting new knowledge from AI and machine learning and implementing it consistently. So it's always nice when the same antibiotic kills, 5 different kinds of diseases. And that's this one antibiotic will do that with all of them.
Yeah, I mean, I could go on all day long talking with you because your knowledge is incredible. And I just also have to call out to our listeners. You also have just an amazing philanthropic heart as well in the work that you do in your personal life. So I just want to say a huge thank you for all you've done for healthcare and all you've done for the world in general, because you've done amazing work. So thank you for that. And thank you for spending time with us. I know we're in the final stages of looking at all the data, and then we're going to start disseminating these results. So do you want to talk about the dissemination plans?
Yeah, I'm so excited about this because once again, I think Brandee, you pointed this out really well. We've given senior leaders, executives in healthcare, an even bigger motivation to deal with something that will bless the lives of every caregiver, of every patient that comes under our care. And so it's just one more reason to try to create healthy work environments, as AACN is all about. So yeah, the goal here is to try to spread the word. First of all, awareness is the first step to change. So everybody who receives a copy of this Silence Kills 2 study, we hope that you'll disseminate it the same way people did so effectively with the initial one in 2005. And then secondly, there's hard work to do, but there's every reason to do it. This will affect our personal lives, our professional lives. And so there's a lot that can be done, and the study will include tips on what can be done to create organizational change. And AACN will be promoting those. We'll be promoting those. And so this isn't just an issue of all of us trying to be more brave and competent. We can do it collectively. And as I shared in this example with hand hygiene reminding previously, it doesn't take months and months and years. We can do this fairly quickly as long as we're determined to follow best practices to implement it. So I hope that in 20 more years, when Vicki and you and I get together and do the next version of the study, it's a 60-70% response, and it can be.
Yeah, and hopefully I'll be around in 20 years to help with that. But and if I am around and kicking for that, I definitely want to be involved, because this is truly passion work for me as well. So we just want to thank you for spending time with us. I know your time is precious, and we appreciate it greatly, being with us today.
It's an absolute pleasure and an honor. There's no industry where I feel like my time and effort could produce a better outcome for others. And so this is where I want to serve.
Well, thank you so much. And to our listeners, we invite you to send any feedback that you might have or ideas for future podcasts to podcast@aacn.org.
Thank you for listening to the American Association of Critical Care Nurses Voices in Nursing podcast, proudly sponsored by AACN's Beacon Award for Excellence, offering unit-level recognition for exceptional units, with information available at www.aacn.org/unit recognition.